Hello everyone. In this topic, I will talk about cardiopulmonary cerebral resuscitation. So, what is this CPCR, cardiopulmonary cerebral resuscitation, and to what kind of patient we do this? Well, we do this to a patient in cardiac arrest. So, what do we mean by word cardiac arrest? Cardiac arrest means when someone has no pulse, no breathing. This is how we diagnose cardiac arrest. No pulse, no breathing. Heart has stopped pumping the blood. So, all the organs are not getting the perfusion, and if we will not intervene, the eventually in few minutes the organs will die. Brain takes 3 to 5 minutes to tolerate hypoxia. After that, if no oxygen will reach through blood, the brain will undergo hypoxic injury. So we need to do something to prevent that, and that is what is cardiopulmonary cerebral resuscitation. That is a first aid maneuver in a cardiac arrest patient to save the organs from hypoxic injury till a definitive management is done. So CPCR, that is cardiopulmonary cerebral resuscitation. As I told you, we do it in a patient in cardiac arrest. Okay, and this is divided into two types: basic cardiac life support, and advanced cardiac life support. Now, basic cardiac life support, it has been designed in such a way that anyone, a non-medical person, a very young, let's say child, can also, if taught properly, can give basic cardiac life support. So it is a very, very basic program, but this forms the foundation of managing a cardiac arrest patient. So we need to have a very good knowledge of basic cardiac life support. But this has been designed for amateurs. This has been designed for non-medical person. So it is very simple. So this can be given by a medical or non-medical person. You just need some training. You don't need to use any sophisticated device or any sophisticated instrument or any sophisticated drug, nothing. Just few maneuvers we have to know. We'll talk about it. Advanced cardiac life support can only be given by the medical care worker, by a medical care workers. Okay. So this needs knowledge of medicine. This needs that we need to recognize some ECG waveform. We need to know some drugs. We need to have some availability of some drugs, how to load it, how to give it. So this is advanced and it requires some monitoring, right? But BLS does not require anything of that such. So let us first talk about basic cardiac life support. Now, to understand basic cardiac life support, which forms the foundation of managing a patient in cardiac arrest, we need to have a full, let's say, knowledge of this flow chart. This is a flow chart which is given by the American Heart Association for managing a patient in cardiac arrest. Okay, and this is a very simple flow chart which we need to understand. So one by one, we will discuss everything about this flowchart, and this flowchart, you can see, this will solve all your question asked on basic cardiac life support, and each and every word of this flowchart is very important from exam point of view, right? So basic cardiac life support. So when do we say a person has gone into cardiac arrest? As I already told you, if person has no pulse, no breathing. Is it necessary if someone is unconscious, he has no pulse, no breathing? No, it is not necessary. So how do we approach, establish cardiac arrest, and how do we manage cardiac arrest? Is the three things we need to discuss in this topic. So when we get a patient or when we come across a person out of hospital, in hospital, anywhere, who seems unresponsive, first thing which we need to see whether the person is responsive or unresponsive, right? So if someone is unresponsive, we go for the BLS approach, that is basic cardiac life support approach. So if we get across some unresponsive person, the first thing which we do is do a scene safety. So first step is we do a scene safety. So there is a possibility that person has become unresponsive in the middle of a road or in a pool or something like that. So we need to make the person safe, and ourselves also safe at a place to do resuscitation. In a burning house, someone has become unresponsive. So we need to first take the patient out of that. So scene safety is a priority. You cannot continue doing CPR if the scene is unsafe or scene becomes unsafe. So scene safety is a priority. We have to establish the scene safety. After scene safety, the second step in an unresponsive person is call for help. So we call for help. So we call our hospital emergency number. We should all know the emergency number where we need to call, and earliest we will get the help. Okay. So we should know that number. So we should call for help. So I have informed the hospital that I have a patient who may be, still cardiac arrest is not established, who may be in cardiac arrest, and we may require automated external defibrillator and a AMBU bag. So these two I have asked for and I have called them. So call for help has happened. After call for help, we need to establish whether the patient is in cardiac arrest or not. So to establish cardiac arrest, we need to see the pulse and breathing of the patient. So pulse and breathing is assessed. So how do we assess pulse and breathing? For breathing, you just have to see the movement of chest. Whether it is an adult or an infant or a neonate, you just have to see the movement of chest to see the breathing. And for pulse, we need to palpate a central pulse. For an adult, which pulse we palpate? It is femoral. Sorry, not femoral. It is carotid, always carotid. For children, we can palpate either femoral or carotid. Anything. Any of these two. And for infant, it is always brachial. Brachial is very easy to palpate in infant. Okay. So remember this. For adult, carotid. For children, femoral or carotid. For infant, brachial. So we put our finger on the pulse and we put our eyes and we focus our eyes on the chest movement and simultaneously try to assess pulse and breathing. Now, three circumstances can come. Patient may have both present. Patient may have pulse present with breathing absent, that is called respiratory arrest, and patient may have both absent, that is called cardiac arrest. So we will manage accordingly. So till now, I have discussed three important points. The sequence is very important. How do you approach an unresponsive person? First, you do the scene safety, then you call for help, and then you assess pulse and breathing. So if I put these things in this flow chart, so first thing for the BLS, verify scene safety. As I told you, that is the first step, right? After scene safety, the patient is unresponsive, the person is still unresponsive, we call for help. So shout for nearby help or call the hospital if you have a mobile, or you can do it very fast. Okay. So activate emergency response system via mobile, right? And ask them to bring a AED and emergency equipment. If you have someone with you, you ask that person to do this, call for help, and you start assessing the patient. But it has to be done. It has to be seen that it is being done, or it has to be done prior to assessing the patient. Okay. So you call for help. After that, we look for breathing and the pulse. So now I am looking for breathing or the pulse. Now, as I told you, breathing, we see by the movement of chest. The number of time the patients can have agonal gasp like this. Now, this is not considered as true breathing. This is agonal gasp. And agonal gasp is not true breathing. So, this is no breathing. So, either there would be no movement of the chest or there can be an agonal gasp. That is no breathing. And we palpate for the pulse. Okay. This has to be done within 10 seconds. So, remember, this has to be done within 10 seconds. The pulse and breathing assessment. And as I told you, we can have three scenarios. Number one, normal breathing and pulse present. Okay. So when the person has normal breathing and pulse, what do I do? So normal breathing and pulse. When this is the situation, definitely the person is unconscious, unresponsive, but not in cardiac or respiratory arrest. So definitely we don't have to do CPR or give rescue breath, anything of that sort. So we need to assess the patient. We never leave an unresponsive person if he has pulse and breathing and go away. We need to hand over the person to the medical personnel if the help is coming. Meanwhile, we need to just present beside the patient, and to prevent any aspiration to happen, we need to make the patient in recovery position. So this is the recovery position. Now this recovery position, as you can see, this position prevents aspiration to happen in unconscious patient. So position prevents aspiration to happen. So patient is made in lateral position, the body is turned, and to maintain that patient in lateral position, the lower limb one limb is kept extended and the other is flexed at 90 degree to prevent the rolling of the patient, and with one arm face of the patient is supported. Okay, so this prevents aspiration. So when normal pulse and breathing is present, wait for ambulance to come. We need to send the patient to hospital to see why the patient is unresponsive, and make the position recovery position, as I told you, right? Recovery position. So this is an important exam question. They ask quite a few times that when do you make someone in this recovery position? When the person is unresponsive and has both pulse and breathing present. Okay, so as you can see in this flowchart also, normal breathing, normal pulse. Monitor until the emergency responders arrive, right? And I am adding, put the patient in recovery position. Okay, now the second circumstances can be no normal breathing but pulse is present. So this is something called respiratory arrest, not cardiac arrest. So if someone is in respiratory arrest, what do we do? If someone is in respiratory arrest, that is pulse present, absent breathing, we give rescue breath. So this is, as I told, respiratory arrest. So in respiratory arrest, this can happen number of times, even in our wards and all. When we give, let's say, I have given my patient morphine for pain relief in post-op patient, and after some time when I came to assess the patient was not breathing, but the patient pulse was still present. So because of the respiratory depression caused by the opioid, the patient is going into respiratory arrest. And if you will not start intervening at this point, the patient may land up in cardiac arrest, right? So in respiratory arrest, how do we manage the patient? We give rescue breath. So rescue breath is given. Rescue breath. Okay, rescue breath is given. So how many rescue breath we give? We don't need to overventilate someone. We just need to give adequate breath. So in let's say every 6 seconds, you give 1 breath. So total 10 breath in a minute. So 10 breath per minute is the rescue breath for adult. And for pediatric, we give 1 breath every 2 to 3 minutes. 2 to 3 seconds, that is 20 to 30 breath in a minute. So for children and infant, we give 20 to 30 breath per minute. So this is given in children and infant. Okay, so this is, let us see the flow chart. So for respiratory arrest, we provide rescue breath, 1 breath every 6 seconds or 10 breath in a minute for adult. And every 2 minutes after giving the rescue breath, we check for the pulse again. And if there is no pulse, patient has gone into cardiac arrest, which is a possibility. Then we need to do CPR. So we give rescue breath for 2 minutes. That is, we will give 20 breath to an adult, and then we will assess the pulse again. If pulse is still present, we will go on giving the rescue breath. If the pulse is absent, we will go for management of cardiac arrest. That is, we'll go for CPR. So let me write this also. So we are managing with rescue breath every 2 minutes. Every 2 minutes, we assess pulse again. We assess pulse again. Okay. And after assessing the pulse, okay, again what we do, depends upon the pulse. If pulse is present, we continue. It is present, we continue with the rescue breath. And if the pulse becomes absent, right, I am not able to feel the pulse, then the patient has gone into cardiac arrest. And then we need to do CPR. Okay. So now coming on the third point, that is, if the patient has no breathing and no pulse. So this is cardiac arrest. So for cardiac arrest, what do? We start with high quality chest compression. So we perform the chest compression, 30 compression, 2 breath, right? And wait for the help to come with automated external defibrillator. So for patient in cardiac arrest, we start high quality chest compression. High quality chest compression. So we'll talk about high quality chest compression. They ask so many times that what are the points for high quality chest compression? So what are the points for high quality chest compression? Number 1, you need to push hard. How hard? Hard enough to depress the chest at least 5 centimeter, right? Not more than 6, but at least 5 centimeter in an adult. In pediatric, at least about 5 centimeter, and in infant about 4 centimeter. So number 1 is push hard, right? So the compression depth, this tells us about the compression depth, hard. Compression depth should be at least 5 centimeter in adult, okay? Then about 5 centimeter in pediatric, in children, and about 4 centimeter in infant. So this is, we are pushing hard, right? And we need to maintain a speed also. So push hard, push fast. So second thing is push fast. So how fast? For any patient, adult, pediatric or infant, the speed should be 100 to 120 compression per minute. It should be 100 to 120 compression per minute. Okay. Third, we are pushing hard, pushing fast, and we need to allow the complete recoil. Because when you push, the heart pumps the blood in the circulation, and you are mechanically letting the heart pump the blood in the circulation, so all the organ is getting the perfusion. And when you allowing the complete recoil, the heart is getting refilled, right? Then only when you will do the push again for the second time, the heart will push the blood into the circulation. If you will not allow the heart to get refilled, your push would be ineffective push. Got my point? So you need to push hard and allow a complete recoil. And remember, the heart gets its perfusion during the recoil, right? So allow complete, let's say, you need to allow the chest to return to its original place. So allow complete recoil. Okay. Then in this process of compression, there should be minimum interruption. When you are compressing, then you are maintaining 30 to 40% of the cardiac output maximum, not more than that. And when you stop the compression at any point, the cardiac output becomes 0. And when you start the compression again, it takes 3-4 more compression for attaining that cardiac output. So any gap or any interruption can be fatal for the patient. So minimum interruption. So minimum interruption in chest compression, right? So minimum interruption in chest compression. And the last point of high quality chest compression is just adequate ventilation. Do not over ventilate the patient. 10 breath in a minute in an adult, 20 to 30 breath in a pediatric and infant. We should not over ventilate, and just see the chest rise to happen. That is we should not fill the huge tidal volume. We should not give a huge tidal volume to the patient. So just adequate ventilation. Why we should not give a huge tidal volume and or overventilate? The reason is that if you will do so, the intra-abdominal pressure would rise and risk of aspiration would increase. And even when you are doing a positive pressure ventilation, you are giving the breath, what will happen? The intrathoracic pressure also increases and venous return decreases, and this would also affect the return of blood into the heart. So it is always, we have to do just adequate ventilation, not over ventilate. So as I told you, in adult, 10 breath per minute. So this is 5 points of high quality chest compression. These 5 points you have to remember. First point is push hard, that is at least 5 centimeter. Push fast, 100 to 120 compression per minute. Allow complete recoil. Minimum interruption in chest compression, and just adequate ventilation. So these are the 5 points for high quality chest compression. Okay. Now, so I started with high quality chest compression with compression and ventilation in a ratio 30:2 for adult, right? Irrespective of how many rescuer we have, 1, 2, 3, whatever. And for pediatric and infant, we go for 30:2 when we have single rescuer, okay, and we go for 15:2 if we have multiple rescuer. So for pediatric and infant, we go for 15:2 if we have multiple rescuer. Okay, so remember this. This is our high quality chest compression. So we do it for 2 minutes. We do it for 2 minutes minimum, uninterrupted. And after 2 minutes, right, we again assess the pulse of the patient. So assess pulse if help has still not come. So again we will assess the required pulse, carotid, femoral in children and in infant brachial. And if there is no pulse, so two things can happen. No pulse. So if there is no pulse, again high quality chest compression for another 2 minutes. And again I will assess the pulse. Okay. The cycle goes on till we receive the help and we get an automated external defibrillator. So I will show you. This is an automated external defibrillator. This should be attached as soon as possible. As soon as we get it, we should attach it. So attach as soon as possible, right? In whatever phase of your compression you are, whatever. When we get this, attach it. You can see this is a very simple device. You just open the lid and you turn on this start button. It will start giving you prompts. First, it will tell you to attach the pads, right? Now, on these pads, you can see images are made where to attach the pad. One we attach on the right side, just below the right clavicle, and the other one in the left axilla, so that the heart is in between these two pads. And when we give the shock, the current goes from one pad, from heart to the other pad and return back to the original pad. So heart, the current is passing. And what is happening? When the current is passing through the heart will stop. And the normal rhythm of the heart is sinus rhythm. There is a possibility the heart will take a normal sinus rhythm if it is not in sinus rhythm. But every rhythm of cardiac arrest is not shockable, will not respond to this shock. So when we attach this automated external defibrillator as soon as possible, the first thing we do, we attach the pad as prompted by this defibrillator. Then what does the automated external defibrillator do? This is automated. So it will assess the rhythm of the patient. So it will assess the rhythm of patient on itself. This will not require your help to assess the rhythm. It will assess by itself. So after assessing the rhythm, this will give us two commands. What? That the rhythm is shockable or non-shockable. So it can give us two commands, shockable or non-shockable, right? So if the rhythm of the cardiac arrest is shockable, we charge the AED and we give shock. We give shock and then we resume compression ventilation. Resume compression and ventilation. If it is non-shockable, then we just resume compression and ventilation. We don't do anything else. We don't give shock. Okay. So once you have attached this AED, you don't need to remove it because this is an automatic machine, and every 2 minutes after assessing the rhythm, it will go again in the phase that let me analyze the rhythm. Again, it will analyze the rhythm and it will tell you shockable or non-shockable, and you have to do accordingly. So in between the AED analyzing the rhythm with that two minutes time period, we do the compression and ventilation after giving shock in shockable rhythm and after not giving shock in non-shockable rhythm. So this is what is your BLS. So if I come back in the chart, again, I would just discuss this chart with you. So cardiac arrest, how do we start? We start the CPR. We perform 30 compression to ventilation. Use AED as soon as it is available. So AED arrives. We attach AED as I told you. Check the rhythm. If the rhythm is shockable rhythm, we give one shock after charging and resume CPR immediately for next 2 minutes until prompted by AED to allow the rhythm check. So as I told you, the AED is an automated device. Every 2 minutes, it will prompt, give a voice prompt, stop compression, let me analyze the rhythm. Till that time, you have to do compression and ventilation. We continue this until the advanced cardiac life support team takes over. And if the rhythm is non-shockable, then we don't give shock. We resume compression, ventilation immediately for next 2 minutes until prompted by AED to allow the rhythm check. Continue until ALS, that is advanced cardiac life support provider, takes over, or maybe the victim has got resuscitated, victim starts moving, right? So you go on doing this till ACLS team takes over, or you have successfully resuscitated the patient, which would be evident by victim moving. Okay, so this is the basic life support, right? This is a flowchart of basic life support, and I explained you for the stepwise. Number 1, we do a scene safety, always remember. Number 2, we call for help. Then we check the pulse and breathing. Check pulse and breathing. And then we do accordingly. Let's assume no pulse, no breathing. So number 4, high quality chest compression. So we start with chest compression. We always start with 30 compression and then we give 2 ventilation. So chest compression and ventilation, that also of high quality. Number 5, use AED, automated external defibrillator, as soon as possible, right? So we use AED as soon as possible. If a shockable rhythm, giving shock as early as possible will increase the chance of successful resuscitation. So we need to use AED as soon as possible. If it is non-shockable, we continue with compression and ventilation. So this is the important points of this flow chart which we need to consider. If you have understood all these points, you will not miss a question on BLS, which is a very important topic. So many times question has been asked in exam. On the sequence, the question has been asked. On the different circumstances, question has been asked, right? Of recovery position, when do you make? Respiratory arrest, what do you do? In cardiac arrest, what is the sequence, right? So everything should be crystal clear in your mind. So I hope you have understood about the high quality chest compression, the 5 important points, and when to use automated external defibrillator. So we go on doing this till the ACLS team takes over. So we continue with basic life support till the ACLS team takes over. Till number 1, the ACLS team takes over. Okay. And number 2, patient starts moving. Patient starts moving. Okay. So this is how we continue with BLS. So let's say patient has not started moving. the ACLS team has taken over. The first thing which the ACLS team do when they take over, they attach the ECG electrodes. So they will, first thing they will do, they will attach ECG electrodes. And when ECG electrode is attached, we will see the rhythm on the monitor. And now the management would be according to the type of rhythm of the cardiac arrest, right? Till here in BLS, we were not seeing the rhythm. The automated external defibrillator was assessing the rhythm. So we didn't have to see the rhythm or give any drug or anything of that sort. But in ACLS, we are doctors now performing ACLS or medical staff performing ACLS. We need to know how to recognize the rhythm, what are the important drugs that we have to give. So now we'll talk about ACLS, Advanced Cardiac Life Support. So as I told you, this is given by medical personnel, okay? So this requires medical personnel. This requires rhythm understanding, requires rhythm recognition. This requires the giving of emergency drugs, and this requires recognizing the cause of cardiac arrest, recognizing and treating cause of cardiac arrest, okay? So these are the few important things that we need to know about ACLS. So let us start. So once ACLS team has taken over, we attach ECG, and as I told, management is according to the rhythm of cardiac arrest. There are two types of rhythm of cardiac arrest, shockable rhythm and non-shockable rhythm. So shockable rhythm, there are two rhythms of cardiac arrest which are shockable. Number one is your ventricular fibrillation, okay? So ventricular fibrillation, okay? Or we popularly call it VF. And number two is your pulseless ventricular tachycardia, okay? So let us rather I should write tachyarrhythmia. It is not tachycardia. It is not a sinus rhythm, so we cannot write tachycardia. So tachyarrhythmia, okay? So these are the two important shockable rhythm. How they do look on the monitor. So let us first see how ventricular fibrillation looks. So if you have given a pencil or a pen to a 1-year-old child, and whatever he does on the paper is your VF. Whatever he draws on the paper is your VF. Got it? My point? See, this is your VF. This lines like this around the baseline, the lines coming up and down. There is no morphology, nothing can be recognized. This is VF. And what about the pulseless ventricular tachyarrhythmia? We will have a very fast rate. The rate would be very fast, but we would have some, let's say, some morphology of the waveform. So there would be some morphology. The waveform would be broad. It would be broad QRS kind, but you will not be able to recognize QRS or anything. So broad, it will be broad, and it can be, right, some morphology, broad, and very high rate of these graphics coming on the monitor. So this can be of two type. Monomorphic, which is on the image. All the waveforms are of same morphology, or it can be polymorphic. That is, all the waveform is not of same morphology. Management is same if we have no pulse. So if we have no pulse, it is cardiac arrest with this kind of ECG waveform seen on the monitor, and the management is same as ventricular fibrillation. So this is ventricular fibrillation. Got it? And that was your ventricular tachyarrhythmia. So why are these rhythms shockable? Well, in ventricular fibrillation, the heart is doing pop, 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 pop like this. And this pop, 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 pop is not getting converted into mechanical output. And in VT, ventricular tachyarrhythmia, heart is beating at a very, very fast rate. no time to get refilled. Again, no cardiac output. In both these cases, in the shockable rhythm, the heart has gone erratic. So we give shock to this erratic heart and stop it and wait for the heart to take its normal sinus rhythm. The normal normal rhythm is sinus rhythm. So by giving shock, we momentarily stop the heart, and we pray, let's say we want the heart to resume its normal sinus rhythm, which in many cases it does, and in many cases it doesn't. So we can give subsequent shocks every 2 minutes. So we can repeat subsequent shock if the rhythm is still shockable every 2 minutes, right? So shockable rhythm. What about non-shockable rhythm? There are two non-shockable rhythm as well. Asystole and pulseless electrical activity. Pulseless electrical activity, or PEA. Pulseless electrical activity, or PEA. Now both these rhythm are non-shockable rhythm. Asystole is a straight line, that is, heart has no electrical activity. And pulseless electrical activity, heart has some electrical activity, but there is no pulse. But that electrical activity is not VF, not VT, and not a straight line is no activity of heart. So if there is no VF and VT and no pulse, but there is some electrical activity seen on the monitor, we call it pulseless electrical activity. This can be sinus rhythm seen on the monitor. This can be AF or a flutter, anything seen on the monitor. So anything electrical activity with no pulse, and that electrical activity is not VF and VT, then it is pulseless electrical activity. Okay, these are non-shockable rhythm, because here there is no problem. I mean, in asystole there is no rhythm, electrical activity of the heart. Why would you give a shock? There is no electrical activity. What you have to stop? And for pulseless electrical activity, maybe heart has a normal electrical activity, but for some reason it is not getting converted into mechanical output. Like for example, patient in shock, no blood in the heart. So heart has electrical activity, but there is no blood to pump. So there is some other cause. So no need to give the shock. So these are non-shockable rhythm. And the management of shockable and non-shockable rhythm differs. So first I will talk about how do we manage shockable rhythm, right? So we will again discuss. So this is asystole, okay, a straight line, okay. And whenever you see asystole, always increase the gain of the ECG, because there are sometimes possible you can have a very fine VF, right, looking like a asystole, and VF has a definitive management in the form of shock. So number of time, whatever cause of cardiac arrest, if patient is in VF, you give a shock, the rhythm can become a sinus rhythm, right? So there is a management in shockable rhythm, but not definitive management in non-shockable rhythm. So we need to distinguish it clearly. So number of time asystole, it seems asystole, but it is a very fine VF. So always increase the gain and check for it, okay? But asystole would be a straight line, okay? Then let us talk about management of shockable rhythm. Shockable rhythm, okay? Ventricular fibrillation and pulseless ventricular tachycardia, okay? And then we will talk about asystole and pulseless electrical activity. And for all, we need to know about this flow chart. So I will discuss this flow chart. This is ACLS flow chart, okay? So first let us talk about the ventricular fibrillation and pulseless ventricular tachyarrhythmia. If the rhythm after attaching, we are doing the BLS, ACLS team came over, they attached the ECG electrode and it was VF seen on the monitor. So if the rhythm is your VF or VT, rhythm is shockable. So we give shock as soon as possible. Then we do CPR for next 2 minutes. And in the meanwhile, when we are doing CPR, we try to have a IV or a IO access, intravenous or a interosseous access if IV access is not possible. Again, after 2 minutes, the rhythm is same VF and VT. Again, we give the second shock. So first shock, and within 2 minutes, we give the second shock after seeing the rhythm still shockable. So every 2 minutes, we have to stop. We have to see the monitor. If the rhythm is still shockable, we give the shock. Again, we start with CPR after shock immediately. No, don't have to assess anything. Immediately, you have to start with CPR. And now you have already put the IV and IO axis, anything, we will start giving the emergency drug, right? And we may consider securement of airway, putting an advanced airway device like endotracheal tube, if the patient is not, let's say, still intubated. So we'll secure the airway device. So we'll put the advanced airway device, confirm it by capnography. Capnography helps us a lot during CPR. I'll talk about it. So 2 minutes I did CPR. Still the rhythm is shockable. Again, I will give the third shock. Every 2 minutes you can give a shock if the rhythm is shockable. And we will do the CPR. Again, the drug which I gave for in shockable rhythm was epinephrine. The first drug, emergency drug, was epinephrine. I'll talk about it. We gave, and we can repeat it every 3 to 5 minutes. If 2-3 shock is not converting the rhythm into sinus rhythm, the shockable rhythm, we can give amiodarone. Amiodarone or lidocaine. Amiodarone, lidocaine, antiarrhythmic agent. They increase the chances of rhythm to get converted into a, let's say, it increases the sensitivity of heart to the shock. So there is a possibility after giving these drugs, the shock which we will give, it can convert the rhythm into sinus rhythm. Okay, so we give amiodarone. Only 2 doses, a first and a second dose of these 2 drugs can be given, amiodarone or lidocaine. Amiodarone is preferred. If it is not there, then only lidocaine. Okay, and we try to find the cause and treat the reversible causes. So this is how we manage the shockable rhythm. So again, I will revise it for you. So how do we manage the shockable rhythm? So we are doing BLS and ECG electrodes attached. ECG electrodes attached. And the rhythm is the VF or pulseless ventricular tachycardia. So these are shockable rhythm. Our priority is shock. So we give shock immediately. So priority is shock. How do I give shock? We give 200 joules of asynchronized shock. Okay, biphasic. Okay, so I gave the shock and we resume compression ventilation. Resume compression and ventilation. And we start, let's say, we start putting IV line, or if it's not possible, intraosseous line. So IV or IO line, we try to fix it. Okay, let's say 2 minutes gone. So resume compression ventilation for next 2 minutes. So 2 minutes gone, I stop and again see the rhythm. Still VF and pulseless ventricular tachycardia. Again, give the second shock. So I gave the second shock. Again, either this 200 joules or we can increase. If I started with 120 joule, I can increase to 150. Then the next shock to 170. So we can increase. So either we can choose the energy of the shock, or we can go for the recommendation given by the manual defibrillator, the company which has made the manual defibrillator, right? So this is, we are giving with manual defibrillator. We are choosing the energy of the shock. Here in ACLS, we use manual defibrillator, not automated external defibrillator. Okay, so we give the shock. After shock, again compression and ventilation for 2 minutes, and we start giving emergency drug. So emergency drugs. So I'll talk about emergency drugs. Okay, adrenaline and amiodarone. We start with adrenaline and we can give amiodarone also. So we start giving emergency drugs, and again 2 minutes gone, same, we see the rhythm, it is still shockable, we again give the shock, right? We again give the shock. We continue with compression and ventilation, and we try to treat reversible cause. Treat if we find reversible cause. So this is how we manage the shockable rhythm. Okay, so what are the important intervention which we did in shockable rhythm? The most important intervention of the shockable rhythm is to give the shock. The second intervention is emergency drug, adrenaline and amiodarone. This is apart from the compression and ventilation which we are doing. Okay, so these are the 3 important intervention, right? We are doing compression and ventilation. We are giving shock every 2 minutes. Shock is a priority in shockable rhythm, and we start giving emergency drugs, and we start finding the cause, right? If it is not getting converted into sinus rhythm, try to find the cause as soon as possible and treat the reversible cause. Okay, so this is how we manage the shockable rhythm. Now let us talk about non-shockable rhythm. Then I will talk about the drugs, etc. So non-shockable rhythm, if it is asystole and pulseless electrical activity. Well, this is non-shockable rhythm. Let us see the flow chart. So if it is non-shockable rhythm, right, we start CPR, we continue CPR, and we give epinephrine, the emergency drug, as soon as possible. In shockable, shock was priority. Here, CPR and epinephrine is the priority. We put an IV IOXs, give epinephrine every 3 to 5 minutes, put an advanced airway, and if the rhythm is still non-shockable, it's still non-shockable, rhythm shockable, still non-shockable, we continue with CPR and we try to treat the reversible cause. Anytime rhythm becomes shockable, we give shock and go into the management of shockable rhythm, right? But if the rhythm is non-shockable, we just continue with CPR, give adrenaline every 3 to 5 minutes, try to find the cause and treat the cause, okay? If rhythm remains non-shockable, still not shockable, right? We just continue with CPCR, got it? And give adrenaline every 3 to 5 minutes. So, for asystole and pulseless electrical activity, CPCR, cardiopulmonary cerebral resuscitation, that is compression and ventilation, adrenaline as soon as possible, adrenaline as soon as possible. Then, after giving adrenaline as soon as possible, we continue. We can repeat it every 3 to 5 minutes. We continue with the compression ventilation. It is always, the drug is always given during compression. So, we continue with compression ventilation every 2 minutes. We see the rhythm. We see the rhythm. If the rhythm is still your non-shockable, we just continue with compression and ventilation. And we give repeat adrenaline every 3 to 5 minutes. So, in asystole and pulseless electrical activity, the compression and ventilation is the mainstay and the adrenaline is the second intervention. No shock, no amiodarone. So, I am writing no shock and no amiodarone or lidocaine, right? So, remember, this is not done in pulseless electrical activity. So, this is how we manage the cardiac arrest. This is the flow chart of ACLS that we need to have full grip on to manage these patients, okay? So, I talked about few interventions, I talked about shock, I talked about the emergency drugs, I talked about the advanced airway. So, let us little bit discuss all those things. Here also, when we are doing the compression ventilation, the CPR quality, it should be the high quality CPR. So, as I discussed, what are the points for high quality CPR? Push hard, push fast, and allow complete chest recoil, right? Minimize the interruption, avoid excessive ventilation, change compressor every 2 minutes or sooner if fatigue. Otherwise, this push hard and push fast will not be maintained. So, it's a very exhaustive work. Change the compressor every 2 minutes. If no advanced airway is there, we do 30 compression to ventilation, and if we put the advanced airway, then we do 100 to 120 compression uninterrupted, and in between the person who is on the airway give 10 breath in a minute. So, till we have not put the advanced airway, 30 compression to ventilation, right? But if once we have put the advanced airway, we do not need to stop compression for ventilation. Compression can go on its own, ventilation can go on its own, okay? And if we have put the advanced airway, it should be confirmed by CAPNO, and quality of compression should be always assessed by CAPNO. So, if I am doing the compression and if I am getting the EtCO2 value more than 20 mm of Hg, this is a good compression, That's tell us about good circulation. And if the EtCO2 is less than 10, then it's a bad compression. Change the compressor, okay? So, after talking about the CPR quality, let us talk about the shock energy for defibrillation in shockable rhythm, only in shockable rhythm. So, biphasic is what we are using nowadays, not monophasic. Most of your defibrillator, the manual defibrillator which we use is using nowadays biphasic. and it is the initial dose is between 120 to 200 joules. We can go on increasing the dose if the first energy is not converting the rhythm into sinus rhythm, right? If unknown, we use the maximum energy which is available. A second and subsequent doses should be either equivalent or higher may be considered. If it is monophasic, still the monophasic defibrillator, you should know your defibrillator, then 360 joules is what we give. What is the difference between biphasic, monophasic? So if this is the chest of the patient, we have attached the parts here and the here. Heart is in between. Heart is in between. For monophasic, the current will pass from the first pad and will go to the second pad. Right? This is for monophasic. Monophasic. So we need 360 joules. If it is biphasic, the current will go, this is heart, and if current will go from one pad to second and will return back to the first pad. This is biphasic, and we give 120 to 200 joules. Okay, less energy is required because it is passing twice from the heart. A lesser energy will do the job. Job is to stop the heart so that heart restart with normal sinus rhythm. Okay, so this is how we do it. Okay, now let us talk about the drug therapy, or before that I told you I will tell you about the capno. What is the role of capno in ACLS? So what is the role of capno? Capnography. It is now advisable whenever you put a tube, advanced airway, attach capnography. It has three important roles. Number one, it will tell us that the tube which you have put, the advanced airway, confirm the advanced airway. So it will confirm the right placement of advanced airway, right placement of advanced airway. Okay. Second, it will tell us about the quality of chest compression. Quality of chest compression. This is one of the most important way to tell us the quality of chest compression. Other is, we see the diastolic pressure if the arterial cannula is put, but that is not always the case. So this is the most important, quality of chest compression with capnography. So how does it tell us? If I am doing the chest compression, I have put the advanced airway and attached the capno. If the capno is coming 10, 10, 10, let's say this is 10. This is inadequate compression. Inadequate compression. We need to change the compressor or improve the quality. If it becomes above 20, then it is a good compression, right? This is good compression. So by seeing the capno, I know the quality of compression. Another role of capno is prognostic, right? See, I am doing the CPR and the capno reading is coming, let's say 20, 25, and suddenly it becomes 40. This means return of spontaneous circulation. Return of spontaneous circulation. Very important. The spontaneous circulation return, the early indicator would be the capno. So when I see a normal graph or betterment of the graph, it is most probably return of spontaneous circulation, right? And one more important use of capno, that if you are doing chest compression and you are not able to increase the ETCO to above 10 for a substantial time period of 25, 30, 40 minutes, it is no use of continuing with CPR, because for that 25, 30, 40 minutes, there is no good perfusion in the body. So most of the organs has undergone irreversible changes or hypoxic changes. Okay, so we need to assess with capno all these things. Okay, so this is the importance of capno. Now let us talk about the drug therapy. Emergency drug. Two important drugs in shockable rhythm. In shockable rhythm, we have adrenaline. Okay, how do we give the drug? Either IV, intravenous. This is the most preferred. Okay, or intraosseous. This is intraosseous if IV we are not able to put. No other way. Intraosseous. This is the next one, next preferred. Okay. Okay. So we put the IV line and we start giving the drug. Epinephrine, 1 milligram every 3 to 5 minutes. 1 milligram adrenaline in 1 in 10,000. 1 in 10,000. Every 3 to 5 minutes. We repeat it every 3 to 5 minutes. No upper limit of adrenaline. And in shockable rhythm, we have another drug, amiodarone. Amiodarone, 300 milligram first bolus and 150 milligram the second bolus. If amiodarone is not available, we can go for lidocaine. First dose 1 to 1.5 milligram per kg body weight, 1 to 1.5 milligram per kg body weight. Second dose 0.5 to 0.75 milligram per kg body weight. We don't give them beyond 2 doses, only 2 doses, not more than that. Okay, this is for shockable rhythm. For non-shockable rhythm, only and only adrenaline. Only adrenaline. Okay, so only adrenaline for non-shockable rhythm. Remember this. Okay, so this is how we manage with the drug therapy. We give the drug therapy. Now, advanced airway, any of it we can put. Endotracheal tube, and if I am not comfortable in putting endotracheal tube, supraglottic airway device, right? And as I told you, it should be confirmed by advanced capnography because it's a very charged atmosphere. So there is always a possibility you put a tube at a wrong place. And once the advanced airway is placed, we give one breath every 6 seconds, that is 10 breaths per minute with a continuous chest compression, as I told you. Okay, so this is important. Now, return of spontaneous circulation. What will happen? The pulse and the blood pressure, abrupt rise in the EtCO2, as I told you, and spontaneous arterial pressure waves in intra-arterial monitoring. So, if the intra-arterial cannula is there, we would get a diastolic recording in that. EtCO2 would increase more than 40 mm of Hg, and pulse and blood pressure would come, right? So, this is how it tells us that return of spontaneous circulation. Now, there are some reversible causes of cardiac arrest. We need to identify those causes as soon as possible for a patient in cardiac arrest and treat the cause to reverse the cardiac arrest. We have 5H and 5Ts, 5H and 5Ts. So, what are the 5H? Hypovolemia, hypoxia, hydrogen ion, that is acidosis causing cardiac arrest, hyperkalemia, and your hypothermia. So, these are the 5H. If we find any of this present in the patient, we treat it. Then only the cardiac arrest will be reversed. And 5Ts are tension pneumothorax, cardiac tamponade, toxin, thrombosis, pulmonary or cardiac. So, these are the 5Ts. Okay, we need to find them. And if apart from this, these are not the only causes. We know there are some cause of the arrest. We try to treat that cause. Okay, so this is how we manage cardiac arrest. Now, what is the role of ultrasound in cardiac arrest? Something new I am adding. Role of ultrasound. Well, if ultrasound help us in making the diagnosis of reversible causes very accurately and fast, bedside ultrasound. If you are trained in bedside ultrasound, you can use it if it is not interfering with compression, chest compression and all. So, there should be minimum interruption in chest compression. That is the most important intervention you are doing in cardiac arrest. So, if you are novice and you don't know how to do ultrasound, don't start practicing in a cardiac arrest patient. But if you are an expert, you can use ultrasound to find the cause, right? If you will put the, let's say, ultrasound and you will put it on the heart, and you may find that the heart is empty. IVC is collapsed. It is hypovolemia. You start giving lot of fluid. The cause will be reversed. If you put the ultrasound and you see it is a tension pneumothorax, right? Then you will do a needle thoracotomy or tube thoracotomy. You will reverse the cause. You can see in the ultrasound, it is cardiac tamponade. You will do a pericardiocentesis immediately. You will reverse the cause. Thrombus you can see in the ultrasound. So, lot of reversible causes can be diagnosed with ultrasound, but only has to be done by an expert, not by a amateur. Okay. So, you can see here, this is a ultrasound image of a pericardial effusion. So, around the heart, there would be black fluid collection. So, pericardial effusion can easily be diagnosed with ultrasound. Then we have, this is a thrombus, coronary thrombus. So, we can see a thrombus in the chamber of the heart, right? And we can make a diagnosis of thrombus and treat it accordingly. The pneumothorax, we can make a diagnosis of pneumothorax with the help of lung ultrasound. So ultrasound can definitely help, but it is only for an expert, because for NOIF, if you are not trained enough, you may take a lot of time in doing it, which will interfere with chest compression, which is the single most important intervention in a cardiac arrest patient, which is saving the life of the cardiac arrest patient by preventing the hypoxic or ischemic injury to the organs, especially your brain. That is why we call it cardiopulmonary cerebral resuscitation, right? So these are the steps of cardiopulmonary cerebral resuscitation. So I hope you have understood. Each and every point which I have discussed with you is a question. So if you go through this, you will not miss a single question coming in exam. So I hope you have understood. Thank you.